Tell me when we are online.
Yes, we are online.
We're online. Hello again, and welcome to the session of Speaking with the Experts. So, did you know infertility is a public health problem during the reproductive age? And it affects about 10 to 15% of couples worldwide. Isn't it surprising? Something which all of us, a lot of people are going through, but probably don't even talk about it. So today we are going to address this extremely sensitive topic of infertility. Hi, I'm Dr. Shilpa Rao, and I'm here today with our panel of experts to speak about infertility. I'm a dentist by profession and the co-founder of the group Endo Crusaders, which is a group to create awareness about endometriosis. I myself am an endometriosis survivor and know the problems that the women face like me. Infertility is defined as a failure to achieve a natural pregnancy after 12 months or more of regular, unprotected intercourse. So, in case somebody is not using contraception and still not able to conceive after 12 months, it is called infertility. People should know what exactly it is. So, for many people, the inability to bear children is a shocking tragedy, and it leads to serious physical, social, and psychological and sexual dysfunction in their lives. Infertility can be either primary or secondary. According to the World Health Organization, the term primary infertility is used when a woman has never conceived. And secondary infertility is incapability to conceive in a couple who has had at least one successful conception in the past. Infertility can be attributed to a lot of anomalies in the past. Infertility has can be because of the male or female reproductive system or both. Several things can disturb the process of fertility at any step, but today we will be discussing female infertility, especially due to endometriosis. Endometriosis is one of the major causes of infertility. So we have with us today Dr. Chandana Lucky Reddy, who has done her master's in obstetrics and gynecology, MRCOG, and British Fertility Fellowship in reproductive medicine and IVF. She has over 15 years of experience of working in various hospitals across United Kingdom. Dr. Chandana has extensive training in IVF and infertility under the who's who of IVF. She has also been awarded certificate in advanced reproductive medicine, pelvic ultrasound, and quality management at United Kingdom by British Fertility Society. Dr. Chandana is a member of Royal College of Obstetricians and Gynecologists and British Fertility Society. She expertises in handling difficult cases of recurrent IVF failures, endometriosis, low ovarian reserve, to just name a few. She's one of the doctors in Hyderabad who has achieved successful pregnancy through the advanced technique of endometrial receptivity array. So, welcome, Dr. Chandana. It's like a pleasure having you with us.
Thank you, Shilpa.
I mean, I was like really, really impressed reading your bio. you know. So, the next expert, as we all know, is Dr. Vimi Bindra. She is a renowned consultant, gynecologist, and laparoscopic surgeon at Apollo Hospitals, Hyderabad. She has completed her basic medical education from RG Kar Medical College, Kolkata, and has done her post graduation in obstetrics and gynecology, followed by diploma in advanced gynecological endoscopy from Dean's Hospital, Mumbai. She has also done her overseas advanced laparoscopy and hysteroscopy training from France. She specializes in fertility enhancing surgeries and has keen interest towards raising awareness about endometriosis. Hence, the group Endo Crusaders was formed. So I and Dr. Vimi together have formed this group to create awareness about endometriosis. Hi, Vimi, back
Hi,
again,
Shilpa. Yes.
doing yet another session.
Yeah.
It's always a
Now
pleasure.
we have IVF experts with us.
I
So
swear, I
uh,
swear. Seriously,
I'm sure we are
seriously.
going to have a wonderful session on this.
Absolutely, absolutely. Last but not the least, Nisha, Dr. Nisha Pansare. I'm so happy to have Dr. Nisha here. I've been knowing Nisha for a while and I've been waiting to call her for our panel discussion once and I got a chance. So, Dr. Nisha is a qualified gynecologist and infertility specialist with expertise in reproductive medicine. She has graduated from the prestigious Government Medical College Miraj and has completed her post graduation in obstetrics and gynecology. She has completed her training at renowned Dinanath Mangeshkar Hospital in Pune and has a fellowship in reproductive medicine and exclusively working in this field since 2013. Her expertise and knowledge of advanced techniques ensure the best possible results and satisfaction for all her patients. She has many successful, difficult, and complex cases to her credit. So I would love to welcome all of you for this evening session and panel discussion on infertility.
Thank you, Dr.
So
Shilpa.
I'm awaiting a wonderful session today. I mean, it's going to be like really interesting with so many people undergoing a problem which people don't even talk about, right? So my first question would go to Dr. Chandana. So, Dr. Chandana, can you tell me how does endometriosis cause infertility and what percentage of women who are infertile is because of endometriosis?
Okay, right. Shilpa, as you were mentioning in the introduction, infertility as such is on rise. Previously, it was around 5 to 10%. Now we can
Yeah.
see almost 15 to 20% couples suffering with infertility due to various reasons. And endometriosis is one of it. So if you see, it can, cause infertility in anywhere from 25 to 50% of couple trying to conceive. And
Correct.
majority of time, we can't even predict that infertility is due to endometriosis because we may not be able to detect this condition in the routine test we do. So we
Correct.
usually for the ovulatory problems, either with your ultrasound or a hormone test, and we look into the tubal factor and we look into the male factor by doing the semen analysis. And if we don't find problem in any of these problems or the investigations, we put them into a category called unexplained. But
Explain.
recent studies have shown in couple who have been put into this category have endometriosis in few of them. So
Correct.
I think your second question is how endometriosis can affect infertility or can cause infertility.
Correct. Correct.
So endometriosis actually can affect fertility at every step. That's what I could say. So
Okay.
right from the egg growth, ovulation, egg quality, and also in the severe cases of endometriosis, we have seen because of the adhesions, the tubes also gets affected. So it can impair the transport of the gametes in the tubes.
Correct.
Not only that, it also have immunological and endocrinal problems as well.
Okay.
So whether the woman could face in problem with the release of the egg or quality of the egg or decrease in the egg reserve as such. And not
Okay.
only that, women can also face problems with implantation. So we have
All right.
seen the uterine environment as such gets affected in the woman with endometriosis, which decrease the chances of implantation and pregnancy as such.
Okay, so it is more, a lot of times it is because of the adhesions, right? Which the implantation becomes a little more difficult, correct?
Yeah.
That's what it is, right? A lot of times, majority of the times.
Yeah.
Dr. Vimi, I wanted to check with you. Now, excision surgery, I think, is the gold standard when it comes to endometriosis, correct? So,
Absolutely.
can you tell me how does a surgery enhance fertility and how does an excision surgery for endometriosis help?
Okay. Uh, First, I will just brief what is a fertility enhancing surgery so that everyone understands.
Correct.
As a patient, they should understand why we call it as
What-
fertility enhancing surgery. So there
Correct,
are
correct.
various factors, the surgical factors for infertility, which can be corrected by laparoscopy or hysteroscopic surgeries, such as
Hmm.
fibroids, endometriosis, adhesions. Tubal factors are there, intrauterine factors such as septum, and Asherman syndrome like intrauterine adhesions. These can be corrected by hysteroscopic and laparoscopic surgery, that is a minimally invasive surgery. And any surgery which is done to enhance the conception rate or live birth rate is called as fertility enhancing surgery. Now,
Correct.
as Dr. Chandana has mentioned, that endometriosis causes fertility because of adhesions, tubal movements are not proper, they cannot pick up the egg, the transfer is sometimes tubes are blocked, and the pelvis anatomy is distorted. So, when we do this LAPEX or laparoscopic excision surgery for endometriosis, excision, I would like to tell that we have to remove each and every each and every endometriosis which we can see in the pelvis or other areas should be removed through the roots. That is what is excision. So ablation does not help. So once we do the excision surgery, restore the anatomy and remove the peri-ovarian adhesions. So this enhances fertility in most of the cases. And
Correct.
I would like to mention here that the first surgery should be the best one for endometriosis. Because as soon as we do the surgery, release those peri-ovarian adhesions, the chances of getting pregnant are maximum in the first few cycles. So repeat
Absolutely.
surgeries won't help. So the first surgery, especially for endometriosis, there are various surgeries for fibroids and other disorders. These are also recurrent and being done multiple times. But endometriosis surgery should be the best one when it is done the first time, and should be done by experts, those who can spot the lesions and those who believe in excision surgeries.
Correct, correct. Also, Dr. Bhumi, I've heard a lot of times, pregnancy is not successful because of the inflammation that's there in the body,
Yes.
right? So once the excision surgery is done, the inflammation is also, I think, a little reduced, correct?
Yes, it restores the pelvic anatomy, reduces the inflammation.
So because of that also, I think the chances are much higher, correct?
Yes. That's why I said the first few months after the surgery, the chances of conception are maximum. So it should not be delayed if somebody is trying for pregnancy. So as soon as they undergo excision surgery, they should plan the pregnancy very next
Okay.
month.
Oh, perfect, perfect. There's something called as AMH. So that's what I've heard. I mean, there's a blood test which gives the measurement of AMH and which tells you about the eggs and the fertility. So my question goes to Dr. Nisha. Dr. Nisha, I wanted to know now what exactly is AMH and how does it affect the fertility?
Yeah, thanks for the question. Yeah, AMH is a anti-Mullerian hormone. This is a basic investigation we do on regular basis for fertility patients. It is
Okay.
produced by ovaries, that's granulosa cells of the ovary, and it is a sensitive marker of ovarian response. Basically,
Okay.
it tells us about the quantity and quality what the woman has in her ovary and ovarian reserve. So
Okay.
every female will tell about the AMH, and it will correlate with egg reserve in her ovary, and it coincides with the age as well.
Okay.
And it's important in the prediction of ovarian response. So it
Okay.
affects the fertility in a way that if whenever the AMH is on a lower side, it clearly indicates that your egg reserve has started declining. So general lab values are like 2 to 9 nanogram per ml. But if it
Mhm.
is like less than 2, so that is a borderline AMH, and that should be the warning sign for the further advancement of the fertility treatments.
That's what my second question was coming to you. That
Yeah.
what is the warning bell when it comes to AMH? Like, what is it? What's the number? What's the golden number when it comes that when you have to go for an IVF treatment? And
As
what's
I
the total?
said, yeah, as I said, below 2, if AMH value is below 2, so that is a basic indicator for the like to go ahead with the fertility treatments or to reach to the doctor who can help you with the pregnancy. So
Okay.
generally AMH between 1 to 2 is fine with us because we at least have some number of eggs which are in good quality. So those can be retrieved or can be stimulated in any fertility treatment. So if it is
Okay.
less than 2, it can be elusive in endometriosis cases. So we have to be very vigilant when we do the sonography. Not only the AMH will help us in endometriosis cases. We have to see
Hmm.
for antral follicle count, that is eggs, what we see
Hmm.
in the sonography. So those are the basic things we have to look for, and we have to correlate with the clinical history of the patient, clinical findings, as well as sonography and this
Hmm.
blood test and age. These are the main signs.
Okay. Okay. Makes sense. Makes sense. Vimi, I've heard that the surgeries, whatever surgery is done, that affects the AMH. So, how is it that a surgery can, preserve, which it can preserve the future fertility? I mean, not reduce the quality of the eggs that's there or the number of the eggs because AMH already is like a little lower on a lower side. So, how is it possible?
So endometriosis and endometrioma itself reduces AMH.
Hmm.
So bilateral endometriomas reduces AMH more as compared to unilateral endometriomas. So if somebody
Hmm.
has a healthy ovary and one side endometrioma with endometriosis will have a better prognosis than somebody who has bilateral endometriomas. Now,
Hmm.
various studies on AMH have shown that AMH decreases after surgery, but
Hmm.
1 year follow-up has shown improvement in AMH as well.
Oh, that's nice.
So,
Hmm.
yes. So now, when we do the surgery, it's very important that we find a proper plane between the cyst and the ovarian wall, and we dissect it properly, and
Hmm.
not damage the ovarian cortex, which produces the eggs. And
Okay.
not only 1 year, in 3 months, we have seen increasing AMH.
Oh, that's
So
lovely. That's lovely.
in
Hmm.
some cases,
Some,
we have seen decreased AMH as compared to the preoperative levels, but most of the cases, at 3 months, AMH levels are either equal or little more than that. But
okay.
if you ask me evidence, the studies are for 1 year. So in one
Okay.
year, it usually improves. So this is
Okay.
very important when we do the surgery because
Hmm.
the resulting effect is that during egg retrieval for IVF, fewer number of eggs will be there. So
All right.
simply having severe endometriosis and in particular endometriomas, AMH will be less. So with
Okay.
proper disease removal and treatment, AMH can and does improve in many cases. So
Perfect.
the distinction when we do the cystectomy, it should not be damaging the cortex. The surgeon has to be very careful when they do that. But yes, counseling for the patient is very important pre-operatively. We have to tell her that in spite of taking all the precautions, sometimes we may lose the ovarian reserve or AMH may fall down after the surgery.
Okay.
And in
So a
some
lot
cases,
of
we do tell them that if AMH is very low and endometriomas is small, they can go for egg freezing if she's unmarried or embryo freezing if she's married and planning for IVF. And I think with Dr. Chandana, we have done
yeah, yeah, yeah.
cases like that. They have frozen embryos and we did the surgery and now they are awaiting transfer.
Awesome. Awesome. That's what I'm saying. Now, some hope for people who are actually having issues, who don't even know what's to be done. Dr.
Proper
Chandana.
counseling is important over there, I believe. So
Yeah.
counseling patient about the options available.
Correct, correct. That's what. So, Dr. Chandana, tell me something now. We have been discussing surgical treatments, and we know excision surgery is the best. But I wanted to check with you, in your opinion, what's the role of medical management in endometriosis related endometriosis related infertility?
Medical management actually have a very slim role in endometriosis related infertility. It is
Okay.
more like for the symptomatic treatment. If a patient
Mhm.
is undergoing a surgery or undergoing a treatment for pregnancy, having a severe pain, probably
Hmm.
to control the pain. And there is
Okay.
also a role of medical management along with the surgery, in conjunction with the surgery, either pre or post.
All
Pre,
right.
most often we don't suggest, the disadvantage being if we suppress the hormones or endometriosis before the surgery, we may
Hmm.
not be able to remove endometriosis completely, as we'll not be able to see the lesions which are suppressed.
Hmm.
But post-operatively, we do give, medical management to suppress
Hmm.
the microscopic endometriosis lesions, because we'll not be able to look at these lesions during the laparoscopy. We can only remove
Okay.
the macroscopic. So, in order
Correct.
to suppress and reduce the recurrence of endometriosis, we take the help of this medical management.
All
And
right.
also during our treatments, not only IVF, if you are going for a treatment like IUI, in mild to moderate cases of endometriosis, we do super ovulation with the ovulation induction agents, which are again falls into the medical management.
Correct. 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 That's correct. That's right. Actually, so all in all, medical management in per se in endometriosis is like minimal. I mean,
Yes.
as an adjunct, yes, but only a medical management is not possible, right?
Right.
So, Vimi, what exactly, we've been talking about endometrioma. So, what exactly is endometrioma or a chocolate cyst in a layman term, and how is it managed?
So when basically the endometriotic tissue starts invaginating or grow inside the ovary. So over the years, there is a collection of blood in the ovary that is called as a endometrioma or a chocolate cyst.
Okay.
The chocolate cyst name is given because when we puncture the cyst or when we are doing laparoscopy, it's an old blood coming out and looks like similar to the chocolate, melted chocolate. That's why the name was given chocolate cyst.
Yeah, yeah, yeah.
Okay. So basically, if you ask me the management, one size does not fit all. So it will
Correct.
depend on the patient's age, the size of the cyst, her symptoms, and definitely her requirement and acceptance to the treatment.
Hmm. Correct.
Now, a very young girl who is having a less than 3 centimeter endometrioma, no symptoms at all, we can still wait. But
Okay.
anybody who is having an endometrioma more than 3 centimeter is symptomatic, trying for pregnancy, or uh, has failed treatments earlier,
Hmm.
definitely she needs laparoscopic excision.
Okay. And what are the advantages and disadvantages of a surgical approach, Vimi?
Advantages and disadvantages, as I'm just finishing the endometrioma part.
Uh-huh.
So, some patients, when pain is minimal and fertility is the ultimate goal,
Hmm.
usually, as Dr. Chandra said, ART can help. For
Hmm.
others in whom fertility is not an immediate concern, but in
Hmm.
future they are planning, and
Hmm.
those who have a significant pain component with endometrioma. So
Hmm.
surgical management may be better, or
Okay.
hormonal control of symptoms, but they should be informed that it will not control the disease progression, or it may worsen the disease in later life. So that
Okay.
has to be discussed with the patient and for young girls with their parents, and
Hmm.
should be informed decision. Now,
Hmm.
as you asked me about the advantages and disadvantages of surgical approach, if patient is completely asymptomatic, not planning for pregnancy, if I don't do the surgery, this disease is progressive. It will keep on growing. Now,
Hmm.
this involves the adjacent organs as well.
Hmm.
Sometimes we have seen patients with renal failures, ureteric
Okay.
obstruction, hydronephrosis, and bowel obstruction also.
Because of endometriosis?
Yes. So when it
Oh.
is compressing on the ureter, it can cause a
Hmm.
partial obstruction or a complete obstruction, leading to renal damage and hydronephrosis.
Oh God.
And
Okay.
sometimes endometriosis in the large intestine or small intestine can cause, when it grows into the lumen, can cause intestinal obstruction.
Oh,
And
I'm a
you know if you had a bowel endometriosis. So, if the disease progression will be there, that has to be told to them. So, a patient who is not having symptoms, not planning for pregnancy, this information has to be given to them.
Okay. All
Second
right.
is a patient who is having symptoms or planning for fertility, definitely excision surgery will help them. And if they are
Hmm.
planning for pregnancy, they should immediately go for fertility treatment or spontaneous conception, whichever suits them or the doctor decides for them. Now,
Okay.
advantages of laparoscopic surgeries are, if done correctly or by trained excision surgeon, it enhances fertility,
Hmm.
reduces pain. We have seen patients who can't even walk with endometriosis.
Correct.
So,
Correct.
first of those patients who come with pain, they are looking for fertility also. But the pain is so severe, they say, Doctor, I don't want any children. First, let me reduce this pain. I'm not living,
Absolutely.
I'm dying
Absolutely.
every day.
Correct.
So, it reduces the pain, it enhances fertility, it corrects dyspareunia, painful sex some women have. Some women have painful urination and painful bowel movements, so that can be corrected. Some women have other symptoms such as fatigue, depression, mental illness. So all these are the advantages of surgery. If we give them relief of symptoms and quality of life, these all can be overcome. Now,
Okay.
disadvantages, if you ask me, the major disadvantage in terms of fertility, I would say, is reduced AMH in some cases after the surgery.
Mm-hmm.
Otherwise, it's a multidisciplinary approach where a team will be there involving the colorectal surgeon, a urosurgeon, and those who can deal with the endometriosis at uncommon locations such as lung and under the diaphragm. So if we adopt a multidisciplinary approach, usually the disadvantages are minimal and we have a lot of advantages. Yes, patient counseling is very important, that these complications can happen when we do the excision surgery.
Okay. Okay. Hmm. But I think it's more about the finesse of the surgeon who's doing it. That's
So
what makes all the
yeah,
difference. That's right. So, Nisha, what's your opinion about surgery and how does it impact IVF?
Surgery definitely is useful when we are talking about fertility thing. That is a different story. But if it is in large endometriomas and patient, as she said, that patient doesn't want pregnancy but just wants to get rid of this pregnant pain, so the surgery definitely will help. But in mild or mild to moderate cases of endometriosis, simple uh, ligation, some simple ablation procedures will definitely relieve the pain. And stage 3 and stage 4, definitely it is a gold standard when we have surgery with the endometriosis. That will definitely help with the IVF outcome as well and the ease of doing IVF procedures.
Okay, okay. And can you tell us a little about the clear-cut indications of assisted conception with endometriosis?
See, generally with mild to minimal disease of endometriosis, we can go ahead with super ovulation, controlled ovarian stimulation, and with simple procedures. After the surgery, also the patient is ready for conception on their own. Because in like surgeries where there is like tubal pathology is affected,
Hmm.
so there is a difficulty in oocyte capture or development of oocyte. So simple surgery will help to have fertility on their own. And in
Hmm.
severe cases like tubal pathology is much affected, so in that case definitely IVF is the matter of choice in these patients. And whenever
Okay.
where we find ovarian dysfunction, the endometriomas more than 4 centimeters when we see in the sonography, so those are definitely clear cut indications for surgery and ART.
All right. All right. That's fine. And Dr. Chandana, how successful is ART treatment with endo?
Yeah. So success of ART treatments depends mainly on two factors. So what is the quality of embryo and what is the environment of the uterus where we are transferring this embryo?
Hmm.
As you can see from all our discussion, endometriosis can affect both the factors. So it can reduce the implantation in the uterus, and it also can affect the quality of the oocytes and in turn the quality of the embryo we transfer in the IVF cycles.
Correct.
So, and not only that, it also depends on the age of the female who is undergoing the IVF, and
Hmm.
also which stage she is and how advanced is this endometriosis, whether she had previous recurrent surgeries, and obviously which all will lead to the quality of the oocytes and the quantity of oocytes and the embryos we get.
Okay.
So they will definitely have less success even in the ART treatments if they have any of these factors which I have mentioned,
Hmm.
compared to other women who is undergoing IVF for a different reason.
Okay. All right. Uh, Vinny, tell me one thing that I've seen in a lot of people. A lot of young girls these days are having endometriosis. I mean, you have seen so many of them of late, right? So, for a young girl who is still unmarried but suffering from endometriosis, what should be the best approach?
So a young girl who is not married, suffering with pain and severe endometriosis, LAPEX is the best approach, laparoscopic excision
Okay,
surgery.
excision.
I don't believe in ablation. Whatever we see, we excise it and remove it. Be it grade 1 to grade 4 endometriosis, excision has to be done. Now, when it comes to a young girl who is not even married, we need to look at many options, and we have to do the counseling regarding the recurrence of disease and ovarian reserve.
Okay.
Should also be given the option of egg freezing if marriage is not on the cards. Now, endometriosis is nowhere a reason to get married. So
Correct.
I have many patients, many young girls, they come with their parents, and parents ask us, shall we get her married? So how marriage is going to treat endometriosis, I never understand.
No, but
So
then I think that's one thing which even a lot of doctors say. I mean, I have gone through it, so I can vouch for it. The first thing a doctor tells me is, get pregnant, you'll be off endometriosis. But
getting pregnant and getting married
Yeah.
will not treat your endometriosis, that is for sure.
exactly.
So this is this outlook has to be changed basically, and it is not acceptable that she is told keep suffering in pain till you get married or plan pregnancy. Sometimes doctors are reluctant to do surgery. They say you get married when you plan for pregnancy. Before that, I will do the surgery. So why is that girl should suffer in pain? That is my question.
Correct.
And
Correct.
the egg freezing, as I discussed, she can keep her eggs frozen, and when she gets married, she can go for IVF and get the embryo transferred, or she can conceive spontaneously also. We are doing egg freezing in the anticipation in case she gets the recurrence of disease or she loses the ovarian reserve further. So if she gets married after 5 years, suppose 10 years later, we will have the eggs frozen. And
Correct.
suppose a girl I operated at 25 years of age, at 35 years of age, she gets married and tries for pregnancy. She may conceive spontaneously also.
Correct. Correct.
To,
That's right.
because we don't know who will have the recurrence and how early they will have the recurrence, we can go for freezing of the eggs immediately after the excision.
Perfect. Perfect. So, Dr. Chandana, when do you suggest that egg freezing should be done, and how successful is it? And also, one more thing, how long can the eggs be kept?
Okay. Okay. As Dr. Vimi has touched that egg freezing thing, so the main indication is if they are going to delay the conception, and if we are worried that the ovarian reserve will be on verge if we go ahead with the surgery. So we have to assess and counsel the girl and the parents. So previously we were doing egg freezing mainly for the cancer patients, cancer patient who is undergoing the radio or chemotherapy. But
Correct.
nowadays we have extended this egg freezing for other reasons like social egg freezing. People who doesn't have any problem, but they want to delay their conception for the career or other reasons. And
Okay.
also we can do egg freezing for medical conditions like endometriosis. So if we see that the ovarian reserve can be compromised, and also there is a chance that she might have problem in natural conception in future, by all means we counsel the girl and her parents and encourage her to go for the egg freezing. So
Okay.
your second question was how
Like,
successful, how long?
how successful and how long?
Okay. So egg freezing has become quite successful nowadays with the latest freezing techniques we have. We use a technique called vitrification. This is actually the same technique which we use to freeze the embryos in IVF. With the same technique, we can freeze the eggs, and with this technique, we get almost over 90% of survival rate of the oocytes which we have frozen.
That's
And
nice. That's
success
like a big
rate
number.
depends on at what age we have extracted the eggs and have freezed. So we have done this freezing for an younger female under 30. You will have better fertilization and better success in the future IVFs. But if we have extracted the eggs at the age of 35 and over or over 40, as there is a chance of less quality oocytes or genetically abnormal oocytes with the female age, even the success with this oocytes turning into a healthy pregnancy will be lesser. And how long we can freeze? We can freeze anywhere from 5 to 10 years. Most of the women, if they want to get pregnant, they use it by that time. And we have also seen cases extending their egg freezing beyond 10 years as well.
Oh, that's like a long time. That's like a long time. So that gives a certain amount of hope for these young girls who are not yet married and are having to go for hysterectomy.
Yeah,
So there are a
yeah.
lot of women, Dr. Chandana, who have undergone hysterectomy. I mean, I included. I mean, I have undergone hysterectomy. So it's like at an earlier age than it should be. And hysterectomy is not a treatment for endometriosis. Yes, but adenomyosis, if you have to go for hysterectomy. So what are the best fertility options which are available for these women?
So, as you rightly mentioned, Shilpa, I think that is the role of the reproductive surgery specialist who need to counsel the patients.
Mm,
Endometriosis per se, we don't, if, I mean, ever ask them to go for hysterectomy. But if there is an associated adenomyosis and with
mm,
severe pain and heavy bleeding, probably yes.
mm,
Otherwise, if they have only endometriosis and we remove the uterus, it's not going to help them. And
mm,
the other indication, as you said, for hysterectomy, if they have any other fibroids or any other problem which is affecting them with heavy bleeding or the pain. So,
mm,
what are the fertility options? So, basically, if it is a mild case, if they are not able to conceive naturally, we would
mm,
start the ART treatments like IUI, which is more recommended in mild to moderate because in them the tubal function will not be compromised. So, that
mm,
too, we need to look at the combination of factors. How is the reserve of the woman? And are
mm,
there any other factors like a male factor? So,
mm,
how long she has been trying? So, if she has not been trying for a while, sperm is fine or just borderline, we can try with few cycles of IUI. But if
okay,
we have a severe endometriosis case in which there is a high chance of tubes being compromised as well, we don't
mm,
want to waste much time there with the IUI treatments because the success of IUI is not that much. Then
mm,
probably we will proceed directly with the IVF treatment in which
mm.
we can bypass the tubes completely.
Okay, okay. So the success is obviously much higher.
Yeah. Yeah.
Good. That's right. That's completely agreeable. So, Nisha, can you hear me, Nisha? Hello.
Yes, I
Yeah,
can. Yeah.
yeah. I lost you. Anyway, so I wanted to. Can you just explain certain complications which can happen in IVF with patients with endometriosis?
See, many of the times, if the patient is after surgery and how meticulously surgery has been done,
Correct.
so that is very important in cases of endometriomas, the lap excision of endometriomas. If the cortex is involved in the excision, so we might lose the ovarian tissue and
Mm,
thus the oocyte yield. So that is the
mm,
basic thing to make the embryos, that we have to have good quality of eggs and good number of eggs. So many of the times in
correct.
stage 3, stage 4, like moderate to severe endometriosis, oocyte yield is impaired, and we get
Correct.
less number of mature eggs in cases of endometriosis. That has many reasons behind it. It can be immunological, it can be hormonal, so there are many things behind it. And even if we have good number of embryos, good matured embryos, good so there is lower implantation rate, it's seen in the stage 3 to stage 4 endometriosis, and there it's
Mm,
decrease in fertilization, so that is a challenge for us. And
mm,
with the endometriomas, we have technical difficulties. Generally, if the endometriomas of less size, like 3 centimeter or 4 centimeter, so we generally if don't go ahead with the excision of those endometriomas. So reaching to
mm,
the good eggs is a difficulty. That is a technical difficulty what we face in the oocyte retrieval in IVF procedures. And in this
correct.
cases, generally we prefer frozen embryos, so that has to be taken care of in a good lab setup.
Okay. Okay. So all in all, with all this discussion, what I've realized is there is hope. There surely is hope for women going through endometriosis. So people have to understand that endometriosis doesn't mean that you can't have children. You can have children. You can, feel that motherhood. So endometriosis is a very common disorder with a variety of symptoms. While some people with endometriosis do have fertility issues, many get pregnant and deliver healthy babies. Correct me if I'm wrong. I think there are quite a number of endometriosis patients who get pregnant normally. Correct. So some women may need fertility treatments to become pregnant, and treatment for endometriosis, such as laparoscopic excision and unblocking fallopian tubes, may also help. Surgery does enhance fertility issues, but has to be done by endometriosis experts. So be really, really prudent when you're deciding your surgeon, and so that your ovarian reserve can be taken care of. Young patients can opt for egg freezing, and surgery of young patients should not be delayed if they are not yet married or ready for childbearing. Doing so would just increase the disease progression. So please, 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 I would ask everybody to please go to a doctor, go to a specialist, and get themselves checked if they feel that they have symptoms of endometriosis. You should speak to your doctor and check about the options which are available for you to go for fertility treatments. So thank you, everyone. Thank you, all the doctors. I mean, I had such a nice time listening to what all options are available, which probably a normal person would not even know. So thank you so much.
We have few questions.
Oh, we do? Perfect.
Yeah. So Sri Bhaskara has asked, hello doctors, good to see you all in this platform. Have a lot of thoughts and doubts for endo patients after COVID, and worries if you get pregnant during COVID times, which is really bothersome. Kindly advise on the same. Sri Bhaskara, this COVID is going to stay with us. It's not going anywhere. It is going to be one of the disease in later times, as we have tuberculosis or other viral infections. So take all the precautions, and even if you get pregnant, just have your routine antenatal checkups, and everything is going to be the same as usual. In case somebody is detected with COVID positive also, if you're symptomatic, then the treatment is given. If you're asymptomatic, usually home isolation is being recommended. So there is nothing to get panic or get worried if you get pregnant during this time. Take precautions, try to avoid crowded places, use mask, hand washing. When you are going to hospital, take an appointment and go. Don't overcrowd those places, and try to schedule an appointment with your blood test, ultrasound all together in a day, so that you don't have to go to the hospital again and again. Good. And we have many pregnant women, many infertility. We cannot delay infertility further now. Earlier, 1-2 months, we postponed all the procedures and treatments, but now chronic illnesses cannot be ignored. Otherwise, we will be sitting on another bomb after the COVID. We'll have other issues coming up. So I think we have to continue the routine care, and healthcare should not be stopped anywhere now because of COVID.
No, absolutely. Healthcare can't be compromised. This is one of the situations that we have come into, but I think we'll have to take care of it.
I think Dr. Chandana can answer this. What is donor egg IVF? Can my family member be an egg donor?
Okay. So donor oocyte IVF is like a woman who have a very low ovarian reserve or almost like failed ovaries. We use the egg of a donor and we fertilize it with her husband's sperm and then transfer the embryo back into her womb. So basically she'll be bearing the pregnancy, but the oocytes are from another lady. So according to the Indian law, egg donation should be anonymous. So we cannot use the eggs of a family member.
Okay.
Okay. I think we have already answered this question. Does endometriosis make the patient infertile? Nisha, would you like to say something just?
Yeah, endometriosis definitely, when it is in the mild stages, even it has a adnexal pathology, tubal anatomy is distorted, ovarian dysfunction is caused by endometriosis, thus the patient will have the fertility issues.
Okay.
So,
is there anything else?
Yeah, we have. Is there a possibility of fertility with endometriosis, low AMH, T-shaped uterus, and adenomyosis all on one patient? Would laparoscopy and hysteroscopy assist with fertility?
Right person to answer.
So, Caro has asked this question. Now again, we have to see now AMH is low. We need to know the antral follicle count. age of the patient, and definitely hysteroscopy and laparoscopy we need. Now, adenomyosis, we need to know the size of the uterus, size of adenomyoma. There are so many factors which will determine the outcome in this particular case. So just knowing these facts, I cannot comment on this. But yes, if we assess the patient and we have all the information, then we can just tell you what will be the probability. Definitely, there are patients who have multiple problems and they also conceive. Not 100% I'm saying, but yes, some of the patients, if we do the excision surgery or correct their uterine anomalies, definitely there is some hope.
Okay.
One more question is, one second. How do you determine whether or not someone has endometriosis? Dr.
The
Chandana,
symptoms say it all.
You're right. So symptoms are the most important. As such, like if she's having a severe pelvic pain or severe period pain or pain during the intercourse, so all this can pinpoint us whether she's suffering from endometriosis. Sometimes we can detect it in the ultrasound if she has developed endometrioma in the ovary. But if she have only pelvic endometriosis, I think the only way we can detect it is with laparoscopy, which is the gold standard for diagnosis.
Yeah. So the laparoscopy is the diagnostic and therapeutic option as of now, because peritoneal endometriosis can be missed on ultrasound and even on MRI. So somebody, if they say you have pain and all your reports are normal, so please don't dismiss them and tell them that you don't have any problem. Go home and take painkillers, use hot water bag and enjoy life. So in that case, at least laparoscopy should be recommended and have a look inside her pelvis so that we can find out if peritoneal endometriosis is there or not. So we have some patients who never had like any adenomyosis or ovarian endometriosis or anything. They just had peritoneal implants on the uterosacrals or near the bladder. And the pain was so horrible and severe, they could not even walk.
No, so the first thing, that's what I'm saying, that laparoscopic investigation is something which has to be added. Not many doctors even advise. I mean, when I was also going through it, I don't think anyone ever, even when I was going through a laparoscopic surgery, people never asked, I mean, people never even looked into it. You know, even though I got diagnosed later, but still it was not looked into. So there is a kind of a, casual attitude when it comes to endometriosis because it is chronic. So what I've realized is people think that since it's chronic, any which ways nothing can be done much. So just let it be.
Yeah.
Least realizing the quality of the life gets impacted.
That's what the outlook has to be changed. One more question is there any correlation of endometriosis and low vitamin D? And this can contribute to inflammation.
Okay. Who's answering this?
Now, Nisha, anybody can answer. Is there any correlation? What does the evidence say?
I don't actually find any studies related to this. Vitamin D deficiency can be related to fertility issues, but not to endometriosis per se as such. It can reduce the implantation, increase the miscarriages, but I don't know if Dr. Nisha wants to add.
There are no studies basically with the vitamin D decrease and endometriosis, but many a times it is package actually what we get. So everything is there. Endometriosis is there, as the one of the viewer just asked us a question, if it has a T-shaped uterus, adenomyosis, low ovarian reserve. So it is kind of package when we see the endometriosis, but there are no basic studies seen for the vitamin D decrease with endometriosis.
Okay. All right.
It is like coincidental findings what we get.
Or we need a long-term studies to comment on
that.
There are no studies as of now which prove that.
Yes.
Yeah.
We have a few more questions. Hello, I'm scheduled for a total hysterectomy in 3 weeks. I'm kind of scared. How is the recovery? Jennifer, if you're undergoing a laparoscopic hysterectomy and if you have endometriosis as well, usually again hysterectomy along with excision should be done. I hope you're not undergoing hysterectomy for endometriosis alone, because hysterectomy does not cure endometriosis.
Absolutely.
If it is laparoscopic surgery, usually recovery should be very fast because there is minimal blood loss and surgery time is less and pain is less. and usually you recover in a day or two, and most of the centers do daycare as well. So you can go home the same day or the very next day. One more question we have coming. Questions, 1 second.
But also, I also wanted to say, Vimi, with hysterectomy, it is physically, yes, the recovery is fast, but I think because of the hormones which change now, when it's a total hysterectomy, your hormones completely go for a toss, and then the problems do start happening. So you please have to speak to your, endocrinologist about the medicines which you need to take so that your, hormones are in circulation and you're like a little comfortable. So that's something which has to be taken care of.
Deepika has asked, what are the chances if AMH level is as low as 1.4 and she has already undergone a surgery a year back and cyst has formed again?
So AMH 1.4, I think it is telling us there is a borderline ovarian reserve, but it's still not bad to undergo an IVF treatment. We have done IVFs for the women who have AMH even less than 1 or less than 0.5. So the success will be little on the lesser side because the number of eggs we get and the number of embryos formed and the embryos to be screened, all that will be reduced with the low AMH. But 1.5, we have seen good success as well. I think by all means, you can go for the treatments.
I would like to add to this that 1.4 AMH is definitely not a bad thing for us, as we see many patients with less than that. Even embryo pooling can be done for these patients when we have like one oocyte retrieval procedures, when we have less number of eggs. So we might have another cycle of oocyte retrieval after 2 or 3 months and get the embryo pooling and then transfer all the embryos together. So even that is the option in this borderline ovarian reserve.
Mm-hmm.
As she said, cyst has recurred and we don't know what is the size of the cyst. So again, the management will depend on the size and what is the extent of disease. If it is a small cyst, as Dr. Chandra and Dr. Nisha said, yes, she can go for egg freezing or embryo freezing or embryo pooling. But if she's having a very big endometrioma, then again, we have to reconsider the options.
Correct.
Yeah.
Geet has asked, I have endometriosis in both my ovaries with 6 and 7 centimeters. I had open surgery twice for the rupture of cyst, but it is recurring back in a year. Please suggest what to do. I feel so hopeless. Now, Geet, it all depends whether the excision surgery was done or not, because recurrence is there even if the excision surgery is done. Now, if the disease is not excised completely, as I think you had a rupture of cyst and you underwent an emergency surgery, so who was the surgeon? Who did the surgery? This all will impact your disease in the future. So this time, if you are undergoing surgery because it has recurred, find out a good excision surgeon and schedule your surgery. Discuss all the options if you're planning for fertility also. That might give you a good disease-free interval. Shweta has asked, in mild endometriosis post-excision after failed IUI attempt, would fresh embryo transfer be the way to go or frozen embryo transfer in IVF? IVF consultants, please answer.
Again, if it is mild to moderate endometriosis, as one person has undergone IUI, so I consider it as mild endometriosis. So if it is failed IUI, so we have to go ahead with ART procedures. And if it is the disease is not that severe, so we might have to do the frozen embryo transfer cycle in context when we use GnRH analog to suppress the disease, basically, which gives us better implantation of the embryos. So frozen embryo transfer is preferred anyways nowadays. So that will have a greater pregnancy rate also.
Okay.
I think we are done. So if viewers have more questions, they can keep posting their questions and we will be happy to answer them in the comment section.
Absolutely. So it was like a eye opener for a lot of us. And thank you all again for being on this panel and looking forward to more of discussions in the coming future. Yeah.
Thank
Okay.
you that
Yeah.
you take so much of effort and just for creating awareness. You are
No,
doing a wonderful job.
it is needed, Vimi. I think together, I think we have been working for this only, right? Since the time we have started this group, I think we have been incessantly working towards creating awareness. Because
But it
that's
but
what
it
is
is
needed.
commendable. It is
Yeah.
Thank you.
commendable. You are so busy, and in this era, we have this empathetic approach towards everyone that is very commendable.
Thank you,
Yeah.
That,
Nisha. Thank you
yeah.
so much.
And that actually helps a lot in fertility as well, because as you were rightly telling, it's a lot of time that misguidance will lead majority to be childless. So if we have counseled them properly in the earlier stage, I think they will have a better outcome.
Yeah.
Absolutely, absolutely. That really is. And I think the doctors like you, I think things will be easier for patients.
Yeah.
Yeah, Charlotte. Thank
Yeah.
you
Thank
all.
you.
Thank
Thank
you
you,
all.
Thank you, everyone.
Thanks to all the viewers taking effort to watch this program, and we will get back to you with another session. Thank you so much.
Thank
Thank
Good
you.
you.
night.
Bye.
Bye bye.
Thank
Bye.
Bye.